Reed. Actually, he's with UC Irvine. Hello. He joins us from the Train New Trainers Primary Care Residency Fellowship. Many of you may have heard of this program, as some of your providers may have gone through it. But he's here to talk to us a little bit today about how to incorporate behavioral health elements into your primary care residency training, given the expertise and the experience he has in developing this program. And so I'll hand things over to him to elaborate more as needed, but thank you for joining us, Dr. Reed.
You bet. I'm glad to be here. I'm down in Irvine now, but I was up in this area for about 8 years. I did my training, internal medicine, psychiatry residency program, then I did a pain medicine fellowship, all at Davis. And I was on faculty before I went down to Irvine, and most recently I've been the director of the Psychiatry Consultation Service and the Psychiatry Service. I've also done a lot of medical education, assistant dean for student affairs, one of the dean scholars in the Clinical Foundations program, teaching that, and associate program director for the Psychiatry residency program. And one of the primary reasons for going down south was to do some of these integrated care initiatives in the residency training space. And we're on target to get the second MedPsych program, residency training program going. We've already got the national approved, so we're looking forward to that. For today's presentation, I want to use the example of the Train New Trainers Primary Care Psychiatry Fellowship. I'm the director of education for that. I want to use that as an example. You'll hear it, you'll say, well, this isn't residency education. Now we've had, when I was at Davis, we had our chief residents in internal medicine would go through this, and some from family medicine as well. Had other residents go through it. Any resident can go through the program, and it can really help that way. But I think there's some elements you can take from what we're doing with this program that then you can then incorporate into residency training. Because the primary aim for this program is to capture providers who are finding themselves in a situation where they're taking care of the mental health needs of the population, yet they were not trained for this. Me, primarily, they were trained in family medicine, internal medicine, OB-GYN, pediatrics, some other specialty, but just the nature of how healthcare is delivered and the workforce shortages they find themselves in the mental health arena. So it goes right into our problem, the diminished psychiatric workforce. Need integrated primary care-based psychiatric care solution, some UC Davis innovative solutions we're going to talk about. So some background. When you look at behavioral healthcare professionals by age group, psychiatrists over 60 years old, 45% of the workforce of psychiatrists over the 60 years old. And with psychologists and counselors, social workers, not nearly the same issues, but with psychiatrists, that's the workforce. So if we're going to say, wait for the psychiatrists to come through and help on this, it will not come. It will not come here, and there's a huge shortage, obviously. Here's breaking it down a little more. There's, in orange, we look at first-year psychiatry residents, 9 coming out of Orange County, big county, right? And then first-year child and adolescent psychiatry fellows, 4. So, and you can go through all of it and look, there's 148 coming out of first-year psychiatry residents for all of California and 46 for the child psychiatry. So the work, the pipeline, we're not even coming close. It will never be there. This won't happen. So we're not stepping on anyone's toes by establishing more training in primary care for the thing that you have to see and you have to treat, and our residents will have to treat this. And they can sometimes, with surprise, finish their training and get put out in a clinic site, and then they're like, and you're going to take over the mental health office. Like, whoa, It's like, I remember I had an attending who really liked treating depression and becoming some titration with SSRIs. But, that's where it ends for a lot of the training. Let's look at, okay, so you take that diminished pocket group of providers, and among that diminished group of providers, psychiatrists I'm speaking of, you have 77% of them that take any insurance, even the good stuff, the private health insurance. Only 55% of them take Medicare, and only 46% take Medi-Cal. Okay, so those numbers that we just had, you just got to cut those in half, right? Again, and then you wonder, now I know why. none of my residents can, or myself, why I can't get a referral to psychiatry to go through in a timely manner. You know, they're still suicidal, still in the clinic. Projected supply and demand for psychiatrists. This is 2016, so already most of the times when they do these current utilization scenarios, these will be equal, but they're just saying there's such a deficit already that you're down low. And unmet needs scenario, meaning those that we know need care and we're not meeting that. So already right now, 2006, let's pretend it's 2016, with 2016 supply, we're not meeting it. Now, we move forward, let's go to 2028. Look, there's your supply and there's your unmet need. I think we beat this horse, we get the idea. There's not going to be enough. So what happens from that? There's suboptimal routine mental health care, increased need for unavailable inpatient care. So they're not getting that care. They end up in an inpatient setting, and we all know how many psychiatric beds are available. Not nearly enough. I could have a whole other slide set, and that's where I've been spending a lot of my time at UC Irvine working on solutions for the emergency department, because it's impacted everywhere in California, so impacted. Any of your graduates who go into the small emergency rooms, family medicine, of course, a lot of them are going to be practicing emergency medicine as well. They'll find, you know, that they can be housing or keeping someone in there through their hold. And in Northern California, we say, well, it's just an application for a hold that we keep renewing and renewing and renewing. And it's this foggy legal area that we play with there just because we really want to provide the care. Southern California, they don't do that. They instead, I think they actually just have more LPS designated EDs, or they had more, and now people are dropping their LPS designations, and it is making the flagship UC Irvine the magnet. Now it's just ruining their model for care in the ED because so many of the beds are taken up by the mentally ill population. So then you have impacted primary care centers, because again, those that are seriously mentally ill populations, the bipolar disorder, the schizophrenia, these very, very seriously mentally ill, they're coming to your clinics, your residence clinics, and then you're having to treat or kind of feel like you're Band-Aid or triaging until you can get them over to psychiatry, which can sometimes take a while. All ending up in not excellent patient care. So this is probably the most important slide, because train new trainers is part of maybe a solution where for those providers, either residents who want to join it, sure, or for providers who have gone through their training, they're finding themselves, I'm supposed to be the team leader for this mental health care delivery. I need some more training for that. But also these collaborative psychiatric care, partnering with PCPs to provide much needed psychiatric consultation. Any Davis crowd, UC Davis folks representing? Oh, okay. So Lauren Schur, he's kind of spearheading the collaborative care as far as from the health systems standpoint and their outreach to the community. That way, and it's just a primary care network for UC Davis. That way you have one psychiatrist who's doing population care. So definitely that'll be part of the solution is psychiatrists doing population care. Still will not even close. Then integrated psychiatric care clinics. This is something very, very good when you're thinking of how can I teach my residents more about psychiatric care when our curriculum does not have psychiatric care or psychiatric rotations. Now, I think we have overrepresentation of family medicine here, and I know you do have some bits of psychiatric rotations, thank goodness. You know, and we need to have that in internal medicine and OB and, you know, and all of our other primary care specialties, we really do. But these integrated care clinics, why are these helpful? So have you ever had it where, okay, even if you send a resident over to a psychiatric rotation, you go to that rotation, they're like, it's a spa, I can do my nails between patients. Meaning there's time. There's time. It's not the same pressures. It's not the same pressures. So you can learn facts, you can learn understanding, but then you come back to your primary care specialty and you're like, yeah, but that doesn't apply to the real world because now I have 15-minute appointments. Thank you. Right? So how do you make that work? Well, the idea is in these integrated psychiatric care clinics, you're treating the whole patient, you're taking care of all of their medical issues, all of their OB issues, all their pediatric issues, whatever the primary care specialty is. At the same time, you're taking care of their psychiatric issues. So you kind of contextualize it. See how do you balance the visit We really need to move that hemoglobin A1C while also needing to take care of the bipolar disorder, which is the reason for the hemoglobin A1C being out of control, right? Then there's this is a solution, one thing that there's never going to be enough internal medicine psychiatry trained individuals. Like I went through that program, but there's like, what, 10, 12 in the nation. And there's just, it's kind of like the psychiatric workforce thing, there's never going to be enough. But it can actually kind of just metastasize and have a beneficial effect for all around. For example, I went through the UC Davis med psych program, and I found something. The consult level at UC Davis, we don't get as many consults for capacity assessment from all the other services. We don't get that. Why? Because the internal medicine and the family medicine psych residents, they rotate on all of these services. And they're like, no, stop. For the love. Capacity assessment, really? You want the psychiatrist who doesn't know your procedure and doesn't know all the things that's going on with that to come in here and decide if this patient understands your procedure to say that they can go ahead and do the procedure? No. Come on. And so you get these, when you get these, just you only need to sprinkle the salt of a few of them into these programs, and then they can be doing the education for these other primary specialties and the other residents too. In my internal medicine clinic, I definitely had all from day one, which was really funny because my first 3 rotations were ICU, medicine wards, and then outpatient medicine. But from day one, everyone's like, hey, Matt, I got this patient, and he's got, I was like, I don't know. But you get this, you have kind of like a consultant in the clinic and the cross education, so you get less times where you have your residents prescribing bupropion for primary anxiety. You have less times when they're doing things that just the bread and butter stuff that you normally wouldn't, you shouldn't be doing. You get less of that happening because their colleagues are like, what are you doing? You can get some of that education there. All right. So, since primary care is the de facto mental health care system, we should know a few facts about that. Provide up to 60% of all psychiatric care in the U.S. Up to 40% of primary care patients have a primary active psychiatric problem. Who here thinks that's accurate? Yeah, up to 40%. I mean, it depends on your clinic you're with. But the fellows that I'm working with and I'm mentoring in the TNT program, bless their heart. These are stalwart individuals on the front lines. Their clinic is made up of a lot more than just 40%. They have hardcore mental illness that they're the primary providers for. 50% of patients with mental health referrals do not follow up. Stigma, poverty, language barriers, paucity of psychiatrists, financial constraints. You put it in the EMR, the order, psychiatric consult, and you're like, prayer, good, go somewhere, and goes around, refuse, yes, no, and then go somewhere. They finally get one, and they really do have employment. Patients want to go. Right? So we've all been there, done that. Okay, less than half of primary care patients with mental illness receive any treatment. 50 to 70% of major depressive disorder is not accurately diagnosed or treated in primary care setting. Roughly 80% of all antidepressants are prescribed by non-psychiatrists. There we go. More than half of primary care patients on antidepressants do not meet criteria for major depressive disorder. Only 1/3 of internal medicine residents are comfortable treating major depressive disorder. Hopefully that's changed. That's 2002. So primary care psychiatry training issues. So for all family medicine here, folks, you can rest easy. Upwards of 60% said they were satisfied with the psychiatric training received. Why? Because you have actual rotations, actual time devoted in the curriculum for psychiatry, right? Internal medicine, not great at all. Not satisfied. OB, even less so. Peds, worst of all. Pediatrics. So education equals workforce. So we keep saying, oh my gosh, there's not enough psychiatrists. We've got to just incentivize psychiatry. But, we just saw how many psychiatrists are coming in. Not a lot, right? So there needs to be definitely a ramp up of psychiatry. It's getting competitive. I'm helping all these medical students get into their residency programs. And psychiatry lately is starting to become one of those, you got to be bare minimum 230 to get in. And so for your board scores to get in, and yet it just is senseless. We need to open up more spots, but that's hard to get funding to open up more spots for that. So the TNT Primary Care Psychiatry Fellowship, we're going to go back to this as our template, and then we're going to think about how we can maybe dissect it or take it apart. You can use it in your training programs. Core objectives: to complete a quick and targeted psychiatric exam. How nice would that be to have your residents have the tool? Did you do your exam? Did you do your psychiatric exam? And have it be an exam where it's not taught as it might be in a psychiatric clinic, because you don't have an hour. You don't. Your intake might be a half hour. Your intake might be 40 minutes. It just depends on your clinic. But you don't have that. Having to be a quick, targeted psychiatric examination. Focus on how to treat the common psychiatric conditions, including psychotic conditions, some bipolar things, because frankly, you'll have to just treat it until you can get someone somewhere, or they refuse to go and you have to treat it in your clinics. Your residents will have to do that. And then learning when to refer to mental health specialists, when to I am not treating, I'll continue to do what I can, but you've got to get somewhere else. When is it really urgent to get them somewhere else? And learning how to train other providers. So that's kind of the train new trainer portion. Is we're not only getting those individuals who select themselves or selected by the health system to be part of the fellowship, but they are selected to do that and then disseminate it among their clinic groups. So there's over 50 contact hours with faculty, over 50 contact hours, and over 40 CV credits per learner. It's a longitudinal, it's 1 year learning module, 2 case-based teleeducation learning modules per month. They normally take place at noon, because again, these are providers in practice, and these are residents in training. So they're normally going at noon or at from 5:30 to 6:30, 5:15 to 6:30. There's 2 a weekend, 4-day learning sessions, conferences with duly trained faculty per year. And there's 1 hour a month of mentoring sessions with a faculty member. It's a curriculum provided, textbook. It's a primary care psychiatry, Lippincott, Wolters Kluwer now, it changed that came out not long ago, and it's a certificate program from the Department of Psychiatry from UC Davis and UC Irvine combined. So I wanted to talk a little bit about these teleeducation learning modules, because we already talked about it, you spoke about it, and I so agree. Even this very moment, my talking on this didactic, in the end, our studies show it's kind of useless. It's sad. All right, I'm being a sad. So it's kind of useless. So how do you make lemonade out of these lemons? Because we still, nonetheless, we have to disseminate the information. You have to get some engagement. And now our fellowship's up to 120 fellows. Next year it's probably going to be 230 the fellows. And it's just going up. So how do you scale that? And we were using WebEx before and it had some issues. And so we started using Zoom. Who here's used Zoom? Zoom, if you do not know Zoom, you have to learn Zoom. It is revolutionized the way I do assistanting for student affairs. I do so many Zoom sessions with the students. They get it. Anyone with an iPhone gets it. Anyone can get Zoom. It's that easy, and the collaboration can be fairly good. There's some quirks with it, and they're getting things a little bit better. But in these big sessions, the first problems we had when we started with Zoom, if you just pay for their regular pro account or use it through your institution if they give you a license for it, if you have a free one, you only get 40 minutes. No good. Everything's always an hour. So then you have to get pro. It's cheap though. You get your pro account, but it only goes to 100 participants. So then you got to get the expanded room. but the pro account would be more than perfect for everyone, most of us here. And what you want to do with the sessions is make sure that all your learners can enter, because you might have residents from multiple sites. Let's say you're doing this. Because I know we all have disparate residents all over different sites as they're going through things. And you want to teach sessions, and you want to have them involved, and you want to see their face, and you want to be able to call them out and say, well, what did you do with that? What did you do with that? So Zoom will allow it. But when you get these lower tier plans, everyone comes in and their audio is just blaring. You're having to have one person just dedicated to doing the whack-a-mole, turning off the microphones for everybody. But so we found that the Zoom webinar feature is great. Everyone, I can say your mic never comes on, but when I want it on, I want to point you out. I can select that person, pop them up, the video has to show, then they can talk, and then I can turn back off. It's like, that's good. That works well. They can raise their hand virtually. Anyone can raise their hand, and I immediately cues the speaker, the person doing it. You can call on them and answer the question. Polling features. At first, we're using poll everywhere. Who's used poll everywhere? Anyone? What's nice about poll everywhere?
You can just, everybody can do it from their phone, and right there on the spot, you get my result.
It's awesome. You're like, you all got a phone. I don't care if it's a flip phone. I don't think they make it, but it doesn't matter. You just text in, and you can get participation. That's awesome. And then we found as time went on, we're getting it was about 60% initially doing it, then about 50%, and about 40% in these sessions, even when we had our big slides that were saying, please join the session by texting to this number. It's just one other thing. So the webinars feature has it where you can do the polls built in from Zoom. Much nicer, whatever device they have, they just click on the screen as it comes up. We implemented that a month or two back, and since then our rates are like 80% participation with the polls, and just hold steady. And the immediate feedback after our first session was, oh my gosh, it's so much easier. Yes, we can answer all these things. Yes, we can interact, and we can participate more easily in the polls. Polls are great because they see all the little graphs and bars, and they get to feel stupid if they got it wrong, and not stupid if they didn't, but it's all anonymous and no one cares. It has all those features, but at least you're dragging people into things a little bit more. Also, Zoom's nice. They have features where normally the frame rate is terrible, like 8 frames a second, where you're not going to be able to show video. And you're like, I want to show video. I want to show physical exam. I want to do these things. Now, even for almost any web connection, they have it where you can choose an options set for full screen video. It increases the bit rate a little bit, but it also increases resolution. It works for people. I just used some 3D rendering. I was showing some where we do spinal injections for some of the pain medicine topics. I was using Complete Anatomy. Anyone use that app to teach? Complete Anatomy is anatomy, you can do like cadaver dissection in 3D, and it worked perfect. So Zoom, it's a versatile tool. You can use it. I highly suggest. TNT PCP topics covered. So you're like, what are the core essential things for psychiatry to know? Now, I say this, I can say because I'm a psychiatrist, and it's all right. I know sometimes my psychiatry colleagues get a little bit offended, but no one should be. It's just the truth. Like family medicine, that knowledge base, it's like, okay, internal medicine, all the primary care, it's just like, good luck, it's like forever your project. This is why it's like the masochism of an internist, willing to just like slam their head against it all the time, just love it, want to know more, and really get all that information. Now, psychiatry, it's more circumscribed body of knowledge, right? There's definitely skill sets and more that in-person teaching and stuff you have to know, but these are some of the things that we found just to be core topics, and all of this is supported in the text, the published text that goes with this. But the AMPS primary care psychiatric interview, it changes how your residents can describe what they're seeing from a psychiatric standpoint. Like an AMP screening, what was AMP screening? Because you always want to hurry, and then if you tell your residents to go in there and now I want you to do a psychiatric evaluation, you come back an hour later and you're like, oh, we are so behind. You got stuck on your bipolar screening. It's painful. I mean, you ask them if they've ever been happy, and yeah, they talk about their kid's graduation. I mean, no, that's not the kind of happy we're looking for. You ask them if they have insomnia, and like every other patient that comes to this clinic, they go, yes. There has to be a more targeted way. There is a more targeted way. There's more targeted, higher yield, faster screening ways of doing it. So you say, what did your AMP screening show? Negative report. Oh, it might be manic. You can get right to it. It's very helpful. We teach that in our first in-person conference. Then we teach it in another webinar, and then I ask my fellows about it in the monthly mentoring sessions, just to make sure that they're getting using that. Mental status examination, the language of psychiatry and communication. Teach it right up front. Use it always. Ask when cases are coming. Ask for it. And I give dot phrases and epic that people can use. That is your key. You're teaching residents. You want to do anything psychiatric related, dot phrase it so that then they can, because you think, oh, they're not learning their dot phrasing it. No, they do learn it because they read it as they're dot phrasing it. And it does help. Cultural psychiatry, cover mood disorders, anxiety disorders, trauma-related disorders. The disorders that I get the most demand for is somatic symptom disorder, pain psychiatry, responsible opioid prescribing, personality disorders, and difficult patient encounters. These are the quality of life topics. These are quality of life topics that should be a part of all residency training. Should be a part of all residency training. I'll tell you, as a resident, I hated my internal medicine clinics. I couldn't figure it out. I was so stressed. I was like, they don't even burden me. I mean, it's like winky numbers of patients, like 4 or 5, for the first couple of years. I did for 5 years. First couple of years, like 4 or 5. I just find myself so stressed by it. Now, it was a little bit of an end destination clinic, meaning patient failed this one, this one, this one, this one. This clinic, we take all, we will accept all, and we accept you with your opioids, right? So that's the nature of the clinic. But I couldn't figure out what it was that was just so, ugh. And after my outpatient psychotherapy year, so that was part of my training. I had psych training, 1 whole year of outpatient psychotherapy. I loved my medicine clinic. It's because I understood personality disorders. If you understand personality disorders, even if you don't have to fully understand it, if you understand it partially, you can understand why your day is wrecked. You can understand why you despise your schedule and you don't even know why. You're just like, gosh, and you can understand why you despise your patient. All right, and that's okay to say it, because if you say it, then you can work with it. Anyway, but it really, really did help. It really, truly, and I could stay on time easier. I could move things faster. I knew when to hold a boundary, when to not hold a boundary. It made all the difference. So these, I really emphasize those. I teach those, the difficult patient personality disorders and all the pain stuff and somatic symptom disorders, because that's the core of the patient population that your residents will start to hate their profession because of it once they get out in practice and feel like they got to find something else. That's it, because it's that portion of the patient population that if you just don't understand what's going on or know what buttons to push with that, it can make it just stressful. And that's only a small part of the patient population, but it's enough that it can be very, very burdensome. I'm over time. I'm not sure. Okay. So here's our core faculty. Don't need to know any of this other than we have a lot of combined. We have like 13 different combined trained in family medicine. We have family medicine, sleep medicine, psychiatry, pain medicine, internal medicine, psychiatry. We have 13 total combined faculty and a lot of other faculty, and some have done other consultation liaison fellowships and such. So that helps. Why does it help? Because again, if you have someone who's only lived the culture of psychiatry and only lived the residency of psychiatry, the timing of psychiatry, the visit length of psychiatry, coming and telling how things should be done, often there can be a little bit of a cultural divide where they can say, well, you would not be able to provide good care unless you increase your patient length to 30 minutes. And you can debate it until the cows come home, but it's not going to change the reality that you're going to have your 15-minute slot. And it's going to stay that way for the foreseeable future, right? And so it's helpful to have people who speak both languages, or at least have been really well versed in it. And this is the realities on the ground for a primary care provider. You got to make it snappy. We need to know what we need to know, and so just give us the facts there. Here's the text we use. This is the 2nd edition, just published. So, trainer fellow training attitudes. I did want to show one thing here. We just got. Anyone know Glenn Zhang? Oh gosh, he's amazing. He's Duke trained, med psych, publishes a lot. And Ariel Nykrug, he's a psychologist, pain psychologist. They're new director of research and associate director of research. So we have some exciting outcomes we're working on right now, especially if our cohort members get out. We're wanting to delve into like EMR practice changing, behavior changes like opioid prescribing, different things like that. So we're excited about that portion. So the training attitudes, I received adequate training during my formal education. Most said no, I didn't, 60% of our fellows. And then I'm satisfied with my overall knowledge base in the area of psychiatry. So pre-test, 70% were not. Post fellowship, 65% saying they agreed or strongly agreed. There's some encouraging things, and we have other numbers, and again, we're working on more of the research data for this. So in a nutshell, improving regional mental health access, directed by PCP psychiatrists. We have curriculum nationally recognized. Any of you can buy the Danish book. And this is the tuition. There's OSHPD grants for physicians that are already in practice. The grants don't go for trainees, residents. So residents, they found other interesting ways of getting grants through different ways, but usually it's been a sponsoring program.
County mental health, and Fresno County School.
Yes, they did. Yes, yeah, that's right. You're right. Yeah. And so there's different ways of getting some of that funding taken care of. And then it's a certificate, fellowship completion, ongoing primary care psychiatry mentorship. My fellows through the program, they still call me. I answer and go through those emails and calls. And as we're looking at solutions and as you're thinking of how do I incorporate more psychiatric education into my residency program, it's one thing to get Zoom and do some of these sessions. It's one thing to have maybe text that could help with knowing, well, what is the circumscribed body of knowledge that might be helpful to know. And Sean Hirschford has a great little handbook to the text. He's perfected over a long time.
Still a Bible at our program.
Yes, and it's wonderful. So you can get that too. But it's important that you ally with somebody who has an understanding of what the primary care clinic is like, and it has psychiatry training to be some kind of ongoing mentorship role. Because the fellows, they learn these things in the conference calls. Then they bring their cases to me during the week. They're like, Dr. Reed, I got this. And I always, give my caveat, I'm not providing advice as a provider for this patient. But in these kinds of scenarios, I usually approach it, pop. They're like, oh, but I thought they said, and I was like, well, I think you have it skewed understanding what they were saying in the lecture, or they just said it wrong. But here's how it is. And so you get that work in practice, because that's where I think I see a lot of change in the fellows is when they bring case after case after case after case after case. By the end of the fellowship, their cases are like, well, I think I understand this set. I think I understand this. I think I understand this generally. I was just questioning about this. And you can see them growing because they've been utilizing it. And it's required mentorship. So they have to call and have to be saying something to you for an hour. So doing that can be an important part. Getting co-located clinic, at least co-location with a psychiatrist can help you as you're training, and getting an integrated one where you're treating both in the same visits can really speed along the learning for residents. Some of our partners, counties.
Have you guys looked at, would you know any other programs that do specific psychiatry like this? Just because that is such a dire need that we
It is a
have.
dire need.
Yeah.
Do I know anyone who's doing PED specific? I do not know anyone who's doing PED specific. And we didn't advertise for PEDs coming. They're like, we're coming. Anyway, we want to get in, and they said, okay. So then we had to get some of our, like Anju Korea, she's excellent pediatrician, wellness officer at UCI, who now is the mentor for our PEDS groups. We've incorporated some pediatric topics in it because they're like, I don't care if this is an adult-focused one. We don't have any. Questions?
I think that a nurse practitioner at my clinic has done this, but I felt like she didn't bring much out to the clinic. And unless it was another one in the Bay Area, but I think this is pretty much the only one like this.
I think yes.
Okay, so she probably did. Now she's gone. But even so, like I was the medical director at the time, and I was trying to coach her like at our meetings when you talk. And so she like brought one like little diagram of how to do something, but she really didn't disseminate. So I'm just curious about, that's a lot of money. And
It is a lot of money.
I'm sure that we sponsored it. And it's interesting that you say about the whole psychiatry thing. I never heard that, to try to get her to collaborate with the psychiatrist for some ongoing coaching, but I don't think that happened.
Or even just keep calling her mentor. So I've worked with a lot of the people that I've worked with in the program, well, probably about half have been nurse practitioners. A couple of them have been tasked by, they really got some rubber on the road. I mean, the individual really gained a lot when their group said, you are taking care of this psychiatric problem. And that was her reality. Be it right or wrong, it was her reality. So she was talking a lot with me and really, and then you always have some standout individuals too, like last year, some of our success stories. Like in this next conference we have coming up, it's the skills conference where everything's just skills practice. We're practicing psychotherapeutic techniques. We're going through all these things. But you're supposed to do the whole thing. We get fellows who've had their success stories of becoming the trainer in their location. And one of my nurse practitioners, she had developed protocols, initiatives, and new screening plans. We were like, well, careful, no one loves screenings. We've got to make sure you don't eat carefully deployed. And so people take away different things they do, and we always like it when the sponsoring group requires some things from the people that they send to the program. So I find their participation on the calls with me much more robust.
Maybe communicating that to sponsor organizations would be good.
Yeah.
Because I mean, I was peripheral to it all, but I'm just like, wow, that's a lot of money,
Yeah.
a huge resource that we totally threw down the drain on that person
Yeah.
who's gone now. And just thinking of what was gained and how little we actually was able to be disseminated.
Yeah, it is. It is something that you have to, you're always looking for those people who works when you're looking at it, who is already kind of the ambassador type, where, you always have maybe the interns or the family practitioner or anyone in your practice who's like, I'm kind of a cards guy, hepatology, I'll do that, I love that, or a poem, I'll do that. And someone who has an inclination towards that anyway, I mean, you just kind of know they're going to continue doing that anyway.
Yeah.
They seem to grab it and just run.
That's what we did. So we sent Liana once.
Yeah.
So she was maybe a year out of residency, new faculty, really already interested in this area. Essentially that she's been directing our behavioral health curriculum for like the last 2.5 years. And we also were able to send a couple of residents to participate in the program as well.
And the residents, we saw good success with.
Yeah.
Some of our chiefs who went through and did that, because they're already, as a resident, you're kind of taking the knowledge you just got and you're applying it. And if you think already, oh, it's part of my care, I do this now. I saw that in the county clinic and the Healthy Partners Clinic. That's the insurance for those with no insurance, undocumented. There in Sacramento. One of the graduates, she was never sending out, it's never sending any to psych referrals, and they had a pretty robust integrated care clinic. She's never sent any of those referrals, and she was talking, I just saw her talking all the time with the colleagues like, why do you send them that referral? They're already overburdened. Take care of it. You got to get them off the opioids. That's what we do here. Yes, the anxiety comes up. If they didn't have an anxiety disorder before they went off opioids, they do now, because that's kind of what it is. You got to treat it. It's just like, I was like, oh, she's speaking my language, and she's, really carrying that. So, yeah, you're right. It's got it is an individual thing. It's like any kind of training is what they grab.
One of the unique things about Deborah and her program, she has a newly accredited family medicine program and an F2HC curriculum. She happens to have a faculty member who is double boarded in family medicine psych. I mean, how rare is that, right?
Serena Wu, yes.
From UC Davis.
Yes.
Yes. So my question, I'm going to have to jump into your shoes again, so feel free to smack me. My question is, what could they create in collaboration with you guys because they have such unique resources? I mean, is there something that they should be looking at as they start their new program?
I mean, it depends on what you're having her create and what she's doing. I mean, she's going into any of the, women's health. Because the family medicine side, dual board, they go in all kinds of directions because it's the nature of family medicine. You go in any direction you want, right? And so it depends on what you're wanting to create. We've seen it where you have already that seed of someone who is going to forevermore do that because it's part of their identity. And it's certainly someone who's had that training residency would be that person. Then it's always helpful because you never know what happens with someone when they decide to go somewhere else, to then have that person champion getting other people to get some training because you're not going to have enough combined training, or to just have her do the training for some of these others who can kind of split shift, what are you creating with her?
Well, we have a block in every year of behavioral health. So she'll be.
And she's doing the integrated care clinic. That will help seed the training to all of your residents. If they have to rotate and see her practice the integrated care in visits. you can even extend those visit lengths because it won't be real live practice, but anytime there's a learner attendant thing, you have to add on another 10 minutes just because it doesn't work otherwise. But getting the residents coming through and rotating the month or whatever with her in the clinic, they're really good results because some of them will pick it up and say, I want to do something like that. And then you can pick them up even if they only stay categorical training once they graduate to help build your program.
Yeah. Probably we will have her do that in the resident clinic.
Yeah. Yeah. Oh, that's great. That's exciting. Yeah.
So kind of following along with what you're saying, do you, besides tracking, maybe tracking where your branches go, do you assess the impact or think of assessing that impact?
Yes, which is why we dedicated a lot of time with our new research initiatives. We right now we have a map of all the different outcomes we're going to be looking at. Some will be the hard data like EMR stuff. Yeah, we'll do all of the softer stuff about knowledge base and all that kind of things. But then also we are tracking and we're doing more of a graduate continuing education where there'll be continued sessions for people who have gone through the program because that'll give us an avenue to see what are they doing now. Because they have to, we'll get some responsible data as they come back for those continuing education about what they're doing, where they're at, and we can see what impact they're having with that.
Hi, Dr. Reed, Alex again.
Yes.
Nice to meet you. Thank you for coming. I am wondering, I appreciate the list of all of the information about patient care skills and clinical skills to have. I wonder if you have any thoughts around what interdisciplinary skills the residents or providers need to have when working with behaviorists, for example. So 85% of health centers report that they have co-located behavioral health LCSW psychologists. And I think that skill, like that bridging of the medical and the behavioral communication is sometimes challenging, but also very important.
Yeah.
Especially when you're talking about like appropriate referrals to therapy and just case conferencing and case planning. Like what comes to mind for you as what skills to build and how to build those?
Yes, I think by the nature of when you're teaching anything that's cross discipline, that language is translatable to other situations, which I think sometimes I see people who do combined programs like the triple board, the med-peds, all these things. They tend to sometimes they do their training, and we get brand data on like family medicine psych and internal medicine psych, what they do. The majority, more than 50%, continue doing both. But there is also a train where they typically go into some kind of administration, probably because they got pounded during their residency program with females from 3 different programs, and the cultures of 3 different, 3 different identities, and kind of got that hammered into them that the world is different. You need to take a different hat, So that does translate, but as far as specific, like partnering with social work and those things, that isn't a current part of the curriculum. We're always, even this year, we're revising what we're going to be doing for the next year because we have limited sessions and deciding on which ones to put in, but it is a key component. It really is. Right now in the emergency department, I don't know if you all are suffering with, well, I shouldn't say suffering, but I will say suffering with the new screening requirements by Joint Commission. Oh my goodness, that is costing us millions of dollars in Southern California. I don't know if it's costing you all money. It's costing us so much money to meet these Joint Commission, and they will ding you if they haven't yet on the new screening requirements for suicide and then the management for them. And so our collaboration and the funds we're putting into social workers and disposition options and different things like that it's gone way up. I feel like I should write a book about collaborations and how to keep things moving in emergency settings for mental health patients who can't get that anywhere.
Yeah, I think I'm just kind of raising for the folks in the room too, and maybe your experience, just how the warm handoff, if not done well, is not going to be effective, and kind of just bridging the communication gap between medical and behavioral. I work with the behaviorists primarily, so I think things that we hear from them is primary care sends everybody with a behavioral health issue to us, and sometimes 80% of them aren't therapy related, and we can't do anything about it. And so I think like the effort that's put in to thinking through like how we bridge those communications will pay off in the long term.
You should email me doctor. Okay.
I just wanted to piggyback because I think those two questions that you guys had are related. And so the example that I used earlier of the site that, had the fortune of being able to get psychology postdoc students in their clinic and have those embedded on the team, the way they structured it is they had a behavioral health faculty member who was a PsyD and who would huddle and look at the patient list with the primary care teams every morning. So during that half an hour huddle, you go around with the list and the postdoc students and the social work students, and they would run the list and say, like, I noticed that this person has this on the problem list, would it be, what is the situation, would it be helpful for us to maybe do a warm handoff with this patient, and the residents would be able to basically think that process out during the huddle, and then depending on how complex the patient was, if the resident knew them or was meeting them for the first time, a lot of different scenarios come up. They might decide that when the patient gets there, they could start with the social worker psychic student, or they could go and do a co-visit together. Yeah. Which again, that co-location part is huge. And that way, the resident and the social work student and the psych student, they're all learning from each other by actually doing a visit together. So that's kind of a huge piece of interdisciplinary training is you can talk about it and talk about it and talk about it, but probably the most effective thing is to actually give people the structure to be able to do it. Yeah. And that really just involves logistically figuring out in your clinic how would that work, how would communication work, how would juggling the timing work, and so it again very much goes back to how you set up your care.
Yeah, and I think to your point about I think you said it was just dealing with personality disorders and how they can be really stressful for the provider themselves. Behaviorists are doing that every day.
Every day, that's what you do.
Every day, right? So if you want to talk about what are some strategies, those are the folks that are also going to have some really probably concrete self-care strategies that might be helpful to.
And Dr. Nitro, who is our Associate Director for Research, he, and this goes to Dr. Bank, our chair's credit, she's really developing a more robust collaboration with psychology at our institution. And now Dr. Nitro and some of the other psychologists that we're onboarding now are doing a significant amount more of the lecturing for our residents, and then taking them and also doing the supervision for their psychotherapy.
Yeah.
Psychotherapy supervision. I've wondered a lot. In my own training, we didn't have a lot of good cross collaboration with psychology, which is not, it's not great, right? Yeah.
I agree on what you're saying, because we have 5 LCSWs. They kind of work in silo. Anyone we think would benefit from therapy we refer, they can't even see a quarter of them. And I don't know if it's the most efficient use of everybody's time. And some are good at getting feedback to us saying, talk to her, she never started the SSRI or whatever, great. And we have a consulting psychiatrist in the county that talks to the LCSWs, which I think is a great model.
Yeah.
So they have it well, kind of the psychiatrist and the LCSW, but for primary care, LCSW, efficient communication and best use of both. I think that is still a ground to be worked on.
That area, the LCSW, that connection right there, we really are working hard on in our residency program. We're starting a whole new collaborative care rotation. This will be a required rotation for our residents, and their main point of contact right now is the LCSW of each of these sites. And what they'll be trained on is how to do that coordination, because they're the point person for the population-based care in each of these individual sites. So incorporating that, I don't know that there are a lot of collaborative care rotations, but we feel like it would be really worthwhile for our residents going through that. That's all. Yeah, that's more on the reverse psychiatry side. Their training rather than being in the primary care clinics. But yeah, it'd be interesting to think about some rotation that way. I know that amount of rotations are a lot you have to pack in.
So I just wanted to say something. My medical director went through this program with you guys, which I'm really thankful for because he did lack the psychiatric component of it, so it could benefit our clinic in that way. And when I was listening to the conversation, I think our biggest challenge from an FQC standing is the collaboration between LCSWs and the doctors. There's always a pushback on both sides. And then you guys were mentioning rotation schedules of doctors and LCSWs or in that area. You can share that resource and show us the structure. I think that's something that we can adopt in our clinics.
Yeah, no, it's a brand new rotation we have going. We're really excited. We've recruited. Actually, we have quite a few because it's an elective rotation, but we have a pack for the year. That's the primary focus of the working rotation. Great, thank you.